Hi, so this video is part of the endocrine system lecture series. This video is particularly looking at the adrenal glands. So anatomically, the adrenal glands are located superior to the kidneys. So here are the kidneys, and this is a dissection of a cadaver. And you can see the kidneys over here and over here. And then you see highlighted in pink is the adrenal gland, which is like this pyramidal glandular structure. And it gets a blood supply from the aorta. And like most endocrine tissue, it is very vascular and very well perfused. And so here you can see this is the abdominal aorta over here, and it would give up a branch to the adrenal glands there. Just to give you a little more context, this is actually where the liver would be, right? And so the liver's been cut away. And over here you can see the spleen, and this is the diaphragm. Okay. So the adrenal gland itself, if we're taking a look at that, you see the cartoon over here on the superior pole of the kidney. And if we were to section through the adrenal gland, it would actually have different layers to it. So here you can see the capsular layer, which surrounds the adrenal gland itself. And then just underneath the capsule, the outermost layer of what we call the adrenal cortex. So the adrenal cortex is sort of the outer tissue layer of the adrenal gland. And the outermost portion of the cortex is called an area called the zona glomerulosa. And then over here, this thicker portion in the middle is called the zona fasciculata. And then down here, this is the zona reticularis. So these three zones actually comprise the adrenal cortex. And so we're going to be talking a bit about the adrenal cortex in this lecture and the hormones that are produced. Over here, you can see the histological section that corresponds with the cartoon over here, with the glomerulosa, the fasciculata, and the reticularis. And then just deep to that is the adrenal medulla. Now, in the autonomic lecture, we learned that the adrenal medulla actually releases epinephrine and norepinephrine as part of the fight or flight response, which I will be coming back to again at the end of this lecture. Now, the suprarenal gland at low magnification, this is anatomically looking at the sections of it. So here is the capsule, which is highlighted in blue. So what you're looking at here in each one of these is a section through the adrenal gland. And if you'll notice this outer layer, I'll just draw your attention to this large picture here first. This outer portion here is the cortex with the layers that I just mentioned on the slide before. And then here, this sort of purplish zone in the center, that is the adrenal medulla. The outermost portion of it here, which surrounds the cortex, is the capsule. And then here highlighted in blue is the cortex, and then the suprarenal medulla, or just the adrenal medulla. These are little spaces in between are the medullary veins. And then if we were to take a look at just the cortex, you can see the zona glomerulosa. This would be the zona fasciculata. And unfortunately, the video here is blocking it, but this would be the innermost layer here, which I'll show you on the big picture here. This would be the reticularis, the sort of reddish zone next to the medulla. So not only is the adrenal cortex anatomically divided by those zones, but those zones actually have different cells which produce different hormones. So for instance, in the zona glomerulosa, which is the outermost layer of the cortex, it secretes something called a mineralocorticoid. The mineral portion of that word really is telling you what the hormone does, in that it actually functions to regulate minerals, particularly sodium and potassium. In other words, the mineralocorticoid that's primarily secreted from the zona glomerulosa is referred to as aldosterone. Aldosterone was discussed more in depth in the renal lecture, but I'll be touching upon it today as well. You'll see in here, in parentheses, I also put the protons here because aldosterone not only reabsorbs sodium and secretes potassium, but it also secretes a proton. In the zona fasciculata, which is the middle layer in the cortex, it secretes glucocorticoids and androgens. So the glucocorticoids, again, based on the name, is going to regulate glucose. So the primary one involved in this is going to be cortisol. And the androgens will have masculinizing effects, and they can produce things like testosterone in peripheral tissues. Now, the androgens we'll talk more about in the reproductive lecture series. The zona reticularis, which is the narrow innermost layer of the cortex, secretes both glucocorticoids and androgen as well. So actually the fasciculata and the reticularis, they both actually secrete glucocorticoids as well as androgens. Interestingly, the androgens in females that are produced in the cortex are actually the primary source of androgen in females. In males, the androgens primarily come from the testes. Again, we'll talk more about that in the reproductive lectures to come. So the hormones I was referring to on the last slide, aldosterone, cortisol, androgens like DHEA, they are all actually derived from cholesterol, and they're known collectively as steroids. So all the steroids that are produced in the adrenal cortex are actually derived from cholesterol. That's the precursor. And so just to kind of give you an idea, to remind you about cholesterol, as you can see here, cholesterol has this very characteristic four-ring structure, which you can see labeled as A, B, C, and D. And it has a side chains over here and some other methyl groups and hydroxyl groups as well. And ultimately, it's a 27 carbon molecule. And what we do is our cortex, or those cells in the cortex, will take cholesterol as its precursor, and then it will convert it into things like cortisol, which down here is a 21 carbon molecule, which you can't see here because of the video. But then 19 carbon could be a testosterone, 18 carbons estradiol, and so on. What's happening is these cells have enzymes, and those enzymes are going to add side chains and cleave some of them off and sort of reframe it around those sort of characteristic four rings there. And that'll produce different properties for those hormones, which will interact with different receptors and different cell types. Okay, so what this slide is showing you now is actually the pathway that's involved in producing the steroid hormones that I was just referring to, and for each of the layers. Let's take a look at that real quick. So if I bring it down to here, and I apologize, it's just taking me a minute, as I'm just getting my pen ready. All right, so here we go. Okay, so over here in the zona glomerulosa, all right, that's right here. That's the outermost layer of the cortex. Now, in the zona glomerulosa, these cells that are located there will take up cholesterol. So you can see cholesterol right here. What you'll notice is that whether I'm talking about the zona fasciculata or the zona reticularis, which are the deeper layers, they all start with cholesterol, okay, as their precursor. And then the first thing that happens is cholesterol desmolase, all right, which is an enzyme located in these cells, will actually convert cholesterol into a common precursor known as pregnenolone. And again, if you compare the pathways, pregnenolone is the same in all of them. Okay, so we're starting out fairly simply. It starts out with cholesterol. Cholesterol is brought in via an LDL receptor, a low density lipoprotein receptor. Once cholesterol is in the cell, it's converted into pregnenolone. Now that happens in every single layer, the glomerulosa, the fasciculata, and the reticularis. And then you'll notice that the pregnenolone, all right, this is where it starts to get different now. If we're just looking at the glomerulosa for now, pregnenolone is converted into progesterone via an enzyme labeled as 3-beta, which we'll come back to. All right, progesterone. And then progesterone becomes deoxycorticosterone. And then deoxycorticosterone becomes corticosterone. And then corticosterone becomes aldosterone. And then you'll notice that at each one of these steps, there's an enzyme. So I had circled over here in red, there's a 21, and then there's an 11. So I'll talk in more detail about that on the next slide. All right, but I circled them because what I want you to notice is that in each of these pathways, they share these enzymes. Okay. Now, of course, this last enzyme down here to convert into aldosterone requires aldosterone synthase. Over here, right, we have pregnenolone again. This is a different pathway, but ultimately in the fasciculata, we're producing cortisol. Now, something I want to make note of is that both the fasciculata and the reticularis will share these pathways. So I'm drawing these arrows just to indicate that in the reticularis will also produce cortisol, which you can see down there. All right. And then you can see in the zona reticularis pathway, just under that, you'll notice the final product there is androstenedione as well as DHEA. Okay, so what I'd like to do for you here is to draw out the pathway, because we do need to know the pathway, and I'm gonna, label the enzymes as we go, because the pathway as well as the enzymes are clinically relevant. So let's do that. All right, so as I mentioned on the previous slide, the precursor for all this is cholesterol. And again, I apologize for my handwriting. I'm getting used to the stylus here. So cholesterol. Cholesterol is taken up into the cells by the LDL receptor. Once the cholesterol is inside the cell, all right, cholesterol gets converted into pregnenolone, which again, as I showed you on the previous slide, was a common precursor for all these pathways. So now pregnenolone gets converted into progesterone. Progesterone will be converted in this particular pathway. We're going to convert progesterone into 11-deoxycorticosterone. And then 11-deoxycorticosterone is going to be converted into corticosterone. All right, and corticosterone is like cortisol, and it is released in smaller quantities from the reticularis and the fasciculata. Now, if we're talking about the glomerulosa, which is the outermost layer, there's one more step. We're going to convert corticosterone into aldosterone. So this is the pathway that is seen in all layers. So you're going to see cholesterol to pregnenolone all the way to corticosterone, where in the fasciculata and the reticularis, it'll stop at that part. So corticosterone will be released in small quantities from the inner layers of the cortex there. It'll go one step further, though, in the glomerulosa, where there's an enzyme that converts corticosterone into aldosterone. All right, so I'm going to write that here for you now. That enzyme is called aldosterone synthase. So aldosterone synthase will actually convert corticosterone into aldosterone. Now, aldosterone synthase is found only in the cells of the glomerulosa and the outermost layer of the cortex. So therefore, they can produce aldosterone, whereas the fasciculata and reticularis cannot. Okay, now let's draw another pathway, because corticosterone, although it is a pathway that is found in the reticularis and the fasciculata, corticosterone is not the major product. In fact, I'm going to draw an arrow from pregnenolone here. Pregnenolone can be converted into 17-hydroxypregnenolone, which can then be converted into 17-hydroxyprogesterone. So far, kind of similar to what we saw in this pathway, except for the 17th carbon is being hydroxylated. And that's going to convert into 11-deoxycortisol. 11-deoxycortisol is then going to be converted into cortisol. Now, cortisol here, that is the main glucocorticoid that is secreted from the reticularis and the fasciculata. Corticosterone is secreted in lesser amounts from that region. Cortisol is secreted by about 10 times as much as corticosterone, and they both have the same characteristics and the same function, ultimately, which we'll talk about a little bit later. Now, in addition to this pathway, it can not only come from pregnenolone and produce either corticosterone or cortisol, depending on the enzymes. It can also take progesterone directly, and it can shuttle it into this pathway as well, producing 17-hydroxyprogesterone. So it can, again, we can either take pregnenolone or progesterone, convert it into 17-hydroxyprogesterone, pregnenolone or 17-hydroxyprogesterone and convert it into cortisol, which again is the primary compound that is secreted there. Now, if you remember, the reticularis and the fasciculata not only release cortisol and corticosterone, but they also release androgens. And in fact, one of the androgens is called DHEA, dehydroepiandrosterone, which you don't need to know the full name there, but DHEA is an androgen. And that DHEA can be converted into another androgen called androstenedione. So now, again, some of the cells in the reticularis and the fasciculatus are going to produce not only cortisol and corticosterone, but DHEA and androstenedione. The androgens can be produced from 17-hydroxypregnenolone or from 17-hydroxyprogesterone. If it's 17-hydroxyprogesterone, that gets converted directly into androstenedione here. All right. So this is the whole pathway really that we need to know. And let's talk quickly about the enzymes. So here, for example, turning pregnenolone into progesterone requires an enzyme called 3-beta HSD hydroxysteroid dehydrogenase. All right, so 3-beta. And it's actually the same enzyme that converts 17-hydroxypregnenolone into 17-hydroxyprogesterone, as well as the same enzyme that converts DHEA into androstenedione. All right, so we're going to see that enzymes are shared throughout these pathways. Okay. Now let's use purple next. All right, so progesterone, to convert that into 11-deoxycorticosterone, we need 21. Sorry, that's a Y. Hydroxylase. 21 hydroxylase. It's the same one over here. It's 20. I'm just going to put 21 here, but it's 21 hydroxylase to convert 17-hydroxyprogesterone to 11-deoxycortisol. All right. And then the last one down here, this one is 11-beta hydroxylase. And I'm just going to put 11-beta over here. But understand this is the same enzyme that's going to convert 11-deoxycortisol into corticosterone, as well as 11-deoxycortisol into cortisol. All right. And then, of course, aldosterone synthase is an enzyme I already previously mentioned, which is the enzyme that converts corticosterone into aldosterone in the glomerulosa. All right, now there's also another enzyme which I haven't yet to mention. All right, which is referred to as 17 alpha, hydroxylase. And the 17 alpha hydroxylase acts over here. So 17 alpha hydroxylase converts pregnenolone or progesterone into the 17 hydroxy molecules. And then over here, 17 alpha, again, I'm just going to put 17 alpha, it's the same enzyme, converts the pregnenolone or the progesterone into DHEA or androstenedione. So, all right, now there's a lot of enzymes here, I realize, and there's, quite a few molecules in this pathway, but you'll notice that there's a lot of similarity. They at least share enzymes and have somewhat similar pathways, which helps us out. All right. So a couple things I want to just highlight for you guys from here. All right, is first off, when we're talking about the enzymes, why is it so clinically relevant? Well, for example, let's talk about this one. All right, 21 hydroxylase. All right, 21 hydroxylase is found in both these pathways that produce corticosterone, aldosterone, as well as cortisol. Now, understand that complete lack of any one of these enzymes could result in death because these hormones are vital to our survival. In other words, we couldn't actually fast for a prolonged period of time without these hormones. Like we can last days or even weeks just on water because of the function of these hormones that they can carry out for us. However, we wouldn't last even much more than a day or two without these hormones. And so they are absolutely vital and necessary for our function. So if we had a complete lack of an enzyme and we couldn't produce the hormone, that typically results in fatality. However, there are deficiencies in these enzymes that can come about, and so they can be inherited deficiencies where you could have a deficiency in the 21-hydroxylase, which is the most common deficiency. And so if I have a deficiency in 21-hydroxylase, that affects both these pathways, this one and this one here. So I'm going to have reduced amounts of corticosterone, cortisol, and aldosterone, and I'll have reduced functionality in whatever those carry out. So for example, in aldosterone, reabsorbs sodium, which brings water with it to help fill up the volume of our blood vessels. It also secretes potassium and protons. If I'm not producing as much aldosterone, you could imagine the person might be more hypotensive, right? They might actually have higher potassium levels. And what ends up happening is the precursors, so for example, pregnenolone and progesterone, those levels would start to rise and they would get shunted. Since they can't move down the regular pathway, they'd get shunted to the right here, and it gets shunted all the way to produce the DHEA and androstenedione, so those levels might start to rise. And so clinically, this is how these enzymes can act. So as another example, if let's say I had a deficiency in the 17-alpha hydroxylase here, that might promote more pathway of the pregnenolone all the way to the corticosterone and aldosterone. So aldosterone levels might actually be elevated, whereas the androgens might be low. And I'm going to come back to this and discuss this in a little bit more detail in the upcoming slides. So this is just showing you what I've already gone over with you. It's just, they drew out the compound structures, which you don't need to know. But here you can see there's cholesterol. So again, this is one, I actually pulled this straight from Wikipedia. So you can see cholesterol here, and then it's cleaved, and you notice that the first step is pregnenolone. Okay, and then pregnenolone, if we go to that pathway, go pregnenolone to progesterone to deoxycorticosterone to corticosterone, and then corticosterone in the presence of aldosterone synthase, which you can see right here, aldosterone synthase, is going to produce aldosterone, which happens in the glomerulosa. And then aldosterone, as you guys know, will help us to regulate things like our blood volume, our blood pressure, and so on. Now, you'll notice that the pregnenolone can also be converted into 17-hydroxypregnenolone, 17-hydroxyprogesterone, 11-deoxycortisol into cortisol. So that's that concurring pathway that I talked about. And cortisol, again, released at higher levels than the corticosterone. But at the bottom there, you'll notice the purple blocks and sort of that pink triangle down there. So what that is, so what you're seeing there is the dehydroepiandrosterone over here, right there. So that's actually our DHEA. And the DHEA can also be converted to androstenedione, which you can see there. And then peripherally, we'll talk about this later, it can be converted into the estrogens, which you can actually see in the pink triangle there. Estrone, estradiol, and estriol are 3 types of estrogen. Peripherally, the DHEA or the androstenedione can also ultimately be converted into testosterone or dihydrotestosterone. And so more of that to come later. So this is what I was referring to a couple slides back when I was referring to the enzymes. There's a condition referred to as congenital adrenal hyperplasia, or CAH. And so what happens is you have a deficiency of an enzyme, not a total lack of an enzyme. Again, because that could be fatal. So the deficiency of the enzyme, the most common one is the 21-beta hydroxylase. And so what that does, and if I'll point that out over here in the cartoon. This is the cartoon that's actually from the PDF notes that I sent you guys. Use this. All right, so we have 21 hydroxylase. So here's the 21 hydroxylase, which I just highlighted in green for you over here. And that converts progesterone into 11-deoxycorticosterone and 17-hydroxyprogesterone into deoxycortisol. So So that's the step. It's shared step. Remember, we're producing corticosterone and cortisol. So that's a shared step, and they share that enzyme. So if we're deficient in that enzyme, I have a reduction. So you notice there's a reduction in cortisol, and there's a reduction in corticosterone. So those are both going to be reduced, which means I'm going to have low levels of that in the bloodstream as well. Okay, so that'll be decreased. Now, what happens is you'll notice that the arrows over here are darker. So what happens is you get a buildup of precursors. So normally it should be going through that pathway with normal functioning enzymes. However, since the enzymes are deficient, we end up with a buildup of progesterone and pregnenolone. That ends up shunting via this 17-alpha hydroxylase that I spoke of. That's going to convert that ultimately into this pathway over here. It's going to shunt it all the way over to these guys, which are our androgens, androstenedione and the DHEA. So androgen levels start to go up because there's a buildup of precursors. And so there's an increase in the androgens in the bloodstream. So there's high levels of androgen, low levels of cortisol and corticosterone. Now in the glomerulosa, remember, that also shares the same pathway to corticosterone. So there would also be low levels of aldosterone. So over here you can see there's reduced cortisol levels. Okay, there's a reduced what we call a negative feedback. So in order to stimulate the production of those pathways that I spoke of earlier, requires the hormone adrenocorticotropic hormone, which we learned from the pituitary lecture, is actually going to stimulate the adrenal gland to produce cortisol as well as those androgens. Keep in mind that ACTH, or adrenocorticotropic hormone, which here I'll highlight here is in the blood, ACTH comes from the anterior pituitary. The anterior pituitary secretes that. It stimulates the fasciculata and the reticularis. It does not stimulate the glomerulosa, so it does not stimulate aldosterone synthesis, but it stimulates cortisol and DHEA synthesis. So it stimulates this pathway normally, but if I'm deficient in 21, it'll stimulate that pathway, and you'll notice that since there's a reduction in cortisol and corticosterone here, that doesn't give any negative feedback to inhibit that. So it continues to produce ACTH at high levels. The ACTH trying to stimulate the cortex to get the cortisol levels to rise. That builds up those precursors that I spoke of, and that shunts it into the androgen pathway. And so there's a lack of that feedback, and ACTH levels will rise. So again, reduces negative feedback, it increases ACTH stimulation. Now ACTH, in addition to its ability to stimulate the production of cortisol and corticosterone as well as the androgens, it also stimulates the cells to grow. So similar to what I talked about with the thyroid stimulating hormone, how it can stimulate those cells to grow, this also stimulates the cells in the adrenal gland as well, and so they can also grow. And so that's why we call this hyperplasia, because the cells are actually, the tissue is actually getting larger. In addition, it can cause increase in pigmentation, because ACTH, not only does it act to stimulate the adrenal cells to release cortisol and androgens, but if it's at a high enough level pathologically, it can also stimulate the melanocyte receptors in the skin. So it's acting like melanin. And so it increases melanin in the skin, or melanin production in the skin, and can cause pigmentation. So again, that's that. The results of this is high ACTH levels, low cortisol and corticosterone, and high androgen levels. And the buildup of those precursors shunted into those pathways for high androgen. Now, what that means for men in general is, you may not see some what we call virilization, or those secondary sexual characteristics of males, but it might be more readily observed in females. And there could also be salt wasting. What I mean by salt wasting, which is my last bullet point down there, salt wasting is because of the lack of aldosterone. Now that's not drawn in the cartoon here, but understand that aldosterone is part of the corticosterone pathway, so it would also be reduced. And reduced aldosterone means the patient could be hypotensive. They could also be losing sodium, which is why I say salt wasting. Sodium is being lost in the urine because we're not reabsorbing it. We're holding on to potassium, so potassium levels could rise. And so these are other factors that you might see. Now I picked 21 because, again, that's the most common. 11-beta hydroxylase would effectively show you the same result. This is just showing you hirsutism, which is showing essentially masculinization type characteristics in a female. And you can see here the hair along the jawline and the chin. So it's basically the formation of a beard, which is a secondary sexual characteristic for males, due to elevated androgen levels, which again could be secondary to one of these enzyme deficiencies that you might see, again, more readily in a female than a male. Now this chart I put in here, this is just to compare mineralocorticoid, which is our aldosterone, versus the glucocorticoid, which is our cortisols. And understand that both aldosterone and cortisol actually can share the same activity. So in other words, aldosterone does have cortisol-like activity or glucocorticoid-like activity. And the glucocorticoids have some mineralocorticoid activity, meaning it can act like aldosterone. Now, you'll see down here in the chart, we have cortisol. All right, so cortisol is going to be sort of our baseline here. So cortisol, all right, it's our average plasma concentrations, average amounts secreted, and so on. So not something that we need to necessarily memorize, but just understand that these dosages are very small on a microgram level. And if we're just to compare those dosages, look at cortisol, average plasma concentration again. Here's 12 micrograms per deciliter. And you compare that to aldosterone, which is 0.006 micrograms per deciliter. So aldosterone is in much, much lower concentration than cortisol is. And corticosterone is lower than cortisol as well. Okay, so you can kind of compare those levels. Now, if we look over here at glucocorticoid activity versus mineralocorticoid activity, cortisols are sort of our reference. So those are normalized to 1, meaning that it has essentially equal glucocorticoid activity as well as mineralocorticoid activity. Now, if we compare that to aldosterone, for example, aldosterone's glucocorticoid activity is very little relative to its mineralocorticoid activity. So therefore, it's going to have primarily the actions of reabsorbing sodium and secreting potassium and so on. Again, cortisol could do the same thing, but it's not one of its primary activities. Now, if we take a look down here quickly at the synthetic steroids, the synthetic ones might be something that we would give a patient, right? So we do give steroids, like for example, cortisone is probably one you guys have heard of. Cortisone is something that we might give to reduce inflammation and so on, and I'll talk more to that in a little bit. But I want you to kind of see that we might pick a particular type of steroid based on some of its functionality, and that would depend on what the patient requires. So for example, here's cortisone, and cortisone has some glucocorticoid activity and some mineralocorticoid activity. It's not quite as potent as cortisol, or efficacious at least. And here's prednisolone, okay? And so here its glucocorticoid activity outweighs its mineralocorticoid activity. Then there's methylprednisolone, and down here, unfortunately, it's a little bit blocked out here, but 9-alpha-fluorocortisol has a glucocorticoid activity of 10 and a mineralocorticoid activity of about 125 or 130, so it has much more mineralocorticoid activity. Why might I choose one versus another? Well, it depends on the patient, right? So for example, there might be a reduction in their aldosterone levels or functionality, and so you might supplement that with fluorocortisol because it has good mineralocorticoid activity, and I might not need the glucocorticoid activity as much. Whereas maybe I need some strong glucocorticoid activity, but I don't want the mineralocorticoid activity, in which case I might take something like dexamethasone. So here's dexamethasone. It has good glucocorticoid activity, about 30 times as strong as cortisol, and there is absolutely no mineralocorticoid activity. So this way I'm not affecting the reabsorption of sodium or potassium or anything. So again, that will kind of dive more into that as we kind of get into clinical examples and later on. All right, so here, kind of summarizing some of the things that I mentioned, there's the mineralocorticoids, right, from the zona glomerulosa, the outermost layer. And again, that's aldosterone. And so it controls extracellular fluid volume because it reabsorbs sodium and water comes with that. If aldosterone levels go down, we don't reabsorb the sodium, it gets excreted in the urine and water follows it into the urine. So it lowers our volume that way. In addition to reabsorbing the sodium, it's also going to be secreting potassium at the same time, so potassium levels are affected by it. And it does influence acid-base regulation because it does secrete protons at the same time as it is reabsorbing sodium and secreting potassium. So therefore, high levels of aldosterone, or excessive levels of aldosterone, let's say, would cause excessive reabsorption of sodium, all right, and water, and cause maybe hypertension. And it would cause a loss of potassium and protons, so therefore the person can become alkalotic and hypokalemic. So here, water is retained with sodium by osmosis. So when it reabsorbs the sodium, the water is following osmotically. All right, this helps us regulate our blood pressure. And it is also part of the what we call the renin-angiotensin-aldosterone system, which we've talked about in the prior kidney lectures. The aldosterone mechanism of action was discussed more thoroughly in the renal lecture, but just to kind of remind ourselves here, we have aldosterone. Aldosterone acts on the cells lining the nephron tubules. So if you recall, that'll act on the late part of the distal convoluted tubule, as well as the collecting duct. And so when aldosterone binds to its internal receptor here, okay, binds to the receptor, then translocates to the nucleus, and it'll produce messenger RNA and proteins. This ultimately has the effect of increasing the sodium-potassium pump to increase our sodium gradient. So there's less sodium here, and compared to the sodium inside the nephron lumen. That's going to drive the sodium into the cell for reabsorption. At the same time, it's going to increase the number of sodium channels. So it increases the gradient and the number of channels, and so sodium is more readily going to go from inside the nephron lumen into the cell here, which will be distributed back into the blood. Water will follow that osmotically. And then what we don't see here is it would also insert potassium channels. So as this pump is working down here to move sodium out, it's putting potassium in. It's building up a high concentration of potassium inside the cell, which will then get moved into the lumen of the nephron to be excreted. So that again will happen because there's an increase in pump activity as well as an increase in the number of channels. What you don't see here is another type of cell called an alpha intercalated cell, where the aldosterone will actually act on those cells to increase the activity of a proton pump to secrete protons into the lumen as well to be excreted into the urine. So let's talk quickly about a clinical case, or not a clinical case, but a clinical condition called hyperaldosteronism. So if it's primary hyperaldosteronism, we call this Conn syndrome. Now, this could be because you have an adenoma in the adrenal cortex, all right, and the adenoma is just producing excessive amounts of aldosterone. And so the aldosterone levels are elevated. This is going to cause hypertension. Not typical with edema, but it's going to cause hypertension because it's reabsorbing all that sodium and water is following it osmotically. It causes hypokalemia because the potassium is being lost in the urine, as well as alkalosis because we're losing protons too. It's something I mentioned earlier on. We also refer to this as primary hyperaldosteronism because it's coming from the adrenal gland itself. And I've underlined at the bottom there something called low renin levels. So it's part of the renin-angiotensin-aldosterone system. So if the aldosterone levels are high, that would feed back to reduce the amount of renin. So low renin levels is actually an appropriate response to elevation of aldosterone. And in fact, that could be something that could be checked out clinically to look at the labs and see that the renin levels are low and aldosterone levels are high. And that would suggest a primary hyperaldosteronism. Secondary hyperaldosteronism All right, that's increased renin. So we have an increased renin levels, and that could be secondary to, say, something that's causing edema, renal artery stenosis. Because again, if you have renal artery stenosis, the kidneys aren't being perfused, and so the kidney senses a low volume state, and in a low volume state, it's going to release renin. So the renin levels start to elevate, and as it elevates, it increases aldosterone production. So other conditions like heart failure, nephrotic syndrome, liver cirrhosis, these are all conditions that can reduce flow to the kidneys, and the kidneys therefore will respond to the reduced perfusion by increasing renin to increase aldosterone to help plump up the vessels and increase volume. So to compare the two, primary hyperaldosteronism would have a low renin level because the aldosterone is abnormally high. In secondary hyperaldosteronism, there would be an increase in renin because the renin is causing the aldosterone levels to be high. Okay, so we just got done talking about the glomerulosa and aldosterone. Now the glucocorticoids, cortisol and corticosterone, are released from the fasciculata and the reticularis, and they are released in response to ACTH, or adrenal corticotropic hormone, from the anterior pituitary. Now that stimulates the release of cortisol and corticosterone, which in response are going to carry out some metabolic activities that help us in times of stress. So cortisol is often referred to as a stress hormone because it's elevated during times of, well, whatever's really stressful, right? So PA school, medical school, studying for exams, emotional stress, surgeries, traumas, illnesses. These would all elevate cortisol. And cortisol elevation is actually, an appropriate and a required thing for us to help us sort of survive during those stressful times. So for example, metabolically, it stimulates fat and protein catabolism. So it breaks down fat and proteins. So what's happening here is this. Imagine we're fasting. Now fasting is stressful to the body. So during a fast, cortisol levels would rise. So what happens is this. During that stressful time, we need to maintain glucose levels, because if glucose levels drop, then our brain and our neural tissue, as well as our red blood cells, would suffer and die. And so to avoid that, the body has a mechanism to help keep the glucose levels maintained. So cortisol levels start to rise. Now as cortisol levels rise, that elevates the glucose, it elevates the glucose levels in the blood, and it maintains those glucose levels so that it can supply that to the neural tissue like the brain, as well as the red blood cells that require it because they don't really utilize, or they can't utilize, fatty acids, for example. So what happens is this. In order to raise those glucose levels and maintain them, it's going to stimulate fat breakdown. So those triglycerides that are stored in adipose tissue will be broken down to fatty acids and glycerol and released into the blood. The fatty acids then can be used by most of the tissues of the body for their energy needs, thus saving the glucose. At the same time, it's also going to break down protein in muscle, for example, into amino acids and release that into the bloodstream. The amino acids are going to be taken up primarily by the liver and maybe a little bit by the kidney. And what they're going to do is take those amino acids and turn them into glucose. So we get gluconeogenesis. So that's how it makes glucose, or creates the glucose that's required to maintain the homeostasis. So in this way, we retain glucose in the blood through gluconeogenesis, or we maintain it, and we provide energy for the other tissues so they're not utilizing the glucose with fatty acids. Okay, and so we refer to that again as gluconeogenesis when we take amino acids and convert them into glucose. All right. And so you see here, all right, with amino acids, glucose into blood, this is an anti-insulin effect because insulin would do the opposite. Insulin would drive glucose into the tissues of the body. It would inhibit gluconeogenesis. It would stimulate fatty production. And so it would essentially do the opposite. So cortisol is acting as like an anti-insulin, also reducing the level of insulin as well in the blood to prevent any opposing effect. This helps the body to adapt to stress because it has readily supply of glucose for the brain and the red blood cells, as well as fatty acids for the rest of the tissue to utilize. We'll get into more about ketones and whatnot in the metabolic lecture. In addition to the metabolic activities of cortisol, it also has anti-inflammatory properties. So its modulatory role at physiological concentrations in the blood is not entirely understood, but it does have some sort of suppression, and that suppression is really seen at very high concentrations, right? So if we think about the slide where I talked about cortisone, right, as an anti-inflammatory. Some people are on steroids, large doses of steroids, oral steroids, to help them with certain inflammatory diseases. So it definitely has an anti-inflammatory effect. In addition, though, high levels of cortisol can also increase blood pressure because it has what we call that permissive effect for catecholamines. So the catecholamines have more of a pronounced effect than they normally would. And so this can actually drive the blood pressure to go up. Now, glucocorticoids are released in a rhythmic pattern, as many hormones are. And so there's a circadian rhythm to it, meaning it follows our day-night cycles. And so if you take a look over here, this is cortisol concentration. And you'll notice that the cortisol concentration varies throughout the day, where typically it's highest in the morning during the waking hours, they say. Now, depending on what your sleep cycle is, it may not exactly look like it's at 8 a.m. But for most people, if they're waking up at 8 a.m., they'd get a spike in their cortisol. So those stress hormone levels go up high there, because waking up for most people is stressful. That's not actually the reason for it, but you understand. But here we have an increase in our cortisol, all right? And then it decreases essentially throughout the day up to about midnight. Overnight, it starts to peak a little bit right before waking up again, with little spikes here and there. So there's a rhythm to it. It's, again, you can get bigger spikes throughout the day depending on person's stress level, or if they had undergone some sort of trauma or have some type of illness. Then the magnitude of this would be a little bit different, but it would still follow, a circadian pattern. Limbic system, because again, that's the emotional centers of the brain, which can also trigger cortisol levels. And it's, there's feedback inhibition. So under normal circumstances, cortisol levels rise, it should feedback and inhibit the release of adrenocorticotropic hormone from the anterior pituitary. And down here in the box here, I just labeled a few things that can actually induce cortisol release. Fasting, which is the example I mentioned. Fright, temperature extremes of hot or cold, high altitude, surgeries, and so on. This is a cartoon just to show that feedback inhibition. So this is the adrenal gland, and the cortex is highlighted in yellow. Here's the pituitary gland. This is the anterior pituitary, and you see the ACTH is released from the anterior pituitary, interacts with the adrenal cortex to release cortisol and corticosterone. The cortisol, its effects are gluconeogenesis, protein mobilization for gluconeogenesis, fat mobilization to provide that energy, stabilizes lysosomes, which is one of the ways in which it helps to reduce inflammation. So it stabilizes lysosomes by preventing them from releasing their content. And again, it's going to relieve stress, which you see over here, relieve stress. And so that has a way of decreasing the excitatory inputs to the brain then. Now, as cortisol levels rise, it'll also directly inhibit the anterior pituitary to reduce ACTH, as well as inhibit the hypothalamus, which has the corticotropin releasing hormone, which stimulates the anterior pituitary via this portal. Remember, that's our typical pathway, hypothalamus through the portal to the anterior pituitary here. So it can block both the hypothalamus as well as the pituitary gland. And then and this here is just to quickly kind of talk about cortisol and its role in inflammation again. Just as a reminder, inflammation is a complex cascade of events with many different mediators. So we have, let's say, tissue damage activates inflammation. You have things being released like histamine and bradykinin, proteolytic enzymes, and then prostaglandins and leukotrienes, which play a major role in inflammation. And the results of inflammation is really there's going to be an increased blood flow to that area, causing erythema or redness, right? And then there's increased capillary permeability. So there's going to be some swelling, so redness, swelling. All right, some leukocyte infiltration goes to that area. Okay, so we can get some reactivity going on there. This can all cause, swelling and pain, so there can be pain. So inflammation, signs of inflammation, redness, swelling, pain. And then, days to weeks later, then there's ingrowth of fibrous tissue that helps the healing process. And you can see that in the cartoon here. If this was a splinter, the redness, the swelling is probably painful. You can see the leukocytes migrating towards that region there, and they'll be releasing chemical mediators as well. Cortisol's role in all this is stabilize lysosomes, so it doesn't release some of those mediators. It's going to decrease capillary permeability, so it's not as much swelling. It inhibits prostaglandins and leukotriene synthesis. So this actually is one of the major mediators for inflammation. It can also decrease lymphocyte production, B cells and T cells, both in the thymus and in the lymph nodes. And it can reduce fevers via interleukin-1 interference. So it plays a major role there, and so this is why steroids can play or are used typically in cases where there's chronic inflammatory diseases and so on. And here you can see the cortisol's effect on the immune system. So just as an example, here are all the X's. So if we gave glucocorticoids or cortisol, for example, it would decrease circulating lymphocytes, decrease the amount of lymphocytes or B lymphocytes, natural killer cells, the actions of macrophages in general. It does enhance anti-inflammatory mediators, which you can't really see behind this video here, but that's what it says. And it will, in some cases, increase circulating granulocytes. But on the whole, you'll see that its primary function is to reduce inflammation at very high concentrations. But I just want to reiterate that these reductions seen clinically are because we introduce high concentrations to patients when we give them the steroids. Physiologically, however, we don't see a huge reductions in inflammatory responses, but it does seem to modulate inflammation. Now, to that point, chronic levels of stress, like PA school, for example, or medical school, if it's elevated for prolonged periods of time, it does have the ultimate effect of causing one to get sick more often, because what happens is some of the tissues desensitize to the elevated levels of cortisol. When they desensitize, like having reduced numbers of receptors for cortisol and so on, that increases the responsiveness to inflammation and the immune system. And so they become more susceptible or have larger responses to things like the common cold. Another example of a disease involving cortisol is Cushing's disease. So this is the classic where there's excess cortisol. Now, if there's excess adrenal production of cortisol, so it's coming from the adrenal gland, we call that primary, and it's referred to as Cushing's syndrome. All right, that's a syndrome if it's coming from the adrenal gland itself. So that's usually from an adenoma. If there's excess signaling, like from the ACTH, this is what we call secondary because it's not in the gland itself, and we refer to that as Cushing's disease, and that's usually because of an adenoma in the pituitary gland. So an ectopic tumor production of ACTH can also be another cause of it. So there could be tumors that actually release compounds that act like ACTH or mimic ACTH action. Ways in which you could test for that would be things like a dexamethasone suppression test, which we'll get into more detail in the clinical courses. But some of the symptoms, let's talk about that. Some of the symptoms would be high blood pressure, all right, because cortisol has a permissive effect on blood pressure by enhancing catecholamine activity and so on. Hyperglycemia because it produces gluconeogenesis. The hyperglycemia can produce a diabetic effect almost because it also inhibits insulin. The muscles can become thinner and weaker. So the patient is usually weaker and a little bit thinner, typically in the extremities like the arms and the legs. There's something called central obesity, which is interesting because cortisol tends to break down fatty acids and distribute them into the bloodstream. But this suggests that adipose tissue centrally, usually located around the organs and the abdomen, as well as a padding on the back of the neck called a buffalo hump, and some on the face. This adipose tissue might not respond to cortisol in the same manner, and so it might cause more deposition than breakdown. And so you might start to see that kind of obesity, what we call central obesity. So that's what the buffalo hump is, and the quotations there. And the fat deposits in the face is referred to as moon facies. And oftentimes you get thinning of skin and weakening of the bones. So the reason you have thinning of the skin is because it breaks down protein, so we can use amino acids for gluconeogenesis. So that breakdown causes breakdown of things like collagen, which is located in the extracellular matrix of our skin. It can cause it to thin out. Weakening of bones for the same reason, breakdown of proteins and collagen matrix of the bone, which can cause it to weaken. It also has an anti-vitamin D type effect, so it can cause almost like an osteoporosis. And it can cause, particularly in females, it's noticeable, hirsutism, again, sort of secondary sexual male characteristics of facial hair and so on. This is just an example here of a lady who actually had corrective surgery, a removal of an adenoma that was secreting too much cortisol. And this was the before here, and you can see the moon facies, as they call it. And then after the corrective surgery, you see how features went sort of more towards a normal. Okay, so the sex steroids, or the androgens, again, secreted by the fasciculata and the reticularis. They are also stimulated by ACTH, just like cortisol. The androgens are the DHEA, which I mentioned, and the androstenedione. This helps to kind of set libido throughout life for men and women. It does play a large role in prenatal male development. Okay, for women, it's the primary source of androgens for women. In males, the primary source becomes the testes. It can be converted to estrogen in females by other tissues. So basically a small quantity of from the adrenals, but this becomes important after menopause for helping to sustain bone mass because estrogen helps to maintain bone. Okay, so Addison's disease, this is a progressive destruction of the adrenal cortex, either through something like autoimmune disease or tuberculosis, where you're losing the production of all those hormones, the androgens, the cortisol, aldosterone. So some of the symptoms would be something like profound weakness and fatigue. So part of that is lack of cortisol, being able to regulate metabolism and the energy requirements. Fatigue, partly because it probably has a reflection of low blood pressure due to the fact that aldosterone levels are low, so you can't reabsorb the water. Weight loss is a little more complex and not quite fully understood, but it might have something to do with cortisol's interaction with hormones in the GI system. Hyperpigmentation, because ACTH levels are elevated, which stimulates the cells of the skin to increase melanin production. Hypotension, again, because of the aldosterone. Hypoglycemia, because cortisol is one of the main hormones to bring glucose levels up through gluconeogenesis. It's not the only one. We'll talk about a couple others in the next couple slides, but it's one of the primary ones. So the adrenal medulla, we've covered most of this actually already when we were talking about the autonomic nervous system. But just to kind of talk about a few other things, it has a dual nature, acting as an endocrine gland and a modified ganglion, as you know, for the sympathetic nervous system. So if you guys recall, over here in the cartoon, you can see the section of the spinal cord, and here's the sympathetic trunk, or the chain there. And you see going out of the ventral root, goes through the chain, and it actually synapses. So this is actually the preganglionic, that goes all the way to the medulla and interacts with specialized cells referred to as chromaffin cells. Now these chromaffin cells will actually respond by releasing epinephrine and norepinephrine and dopamine, primarily epinephrine, and that will circulate in the blood and cause the effects that we talked about in the autonomic nervous system lecture. Okay, so the catecholamines, when I say catecholamines, I'm referring to dopamine, norepinephrine, and epinephrine. Primarily what's released from the adrenal medulla is epinephrine, and then a smaller amount of norepinephrine, and then finally trace amounts of dopamine. And so you can see this is actually the pathway for its production. So the precursor to it is tyrosine. Tyrosine is converted to dopa, to dopamine, to noradrenaline, and then finally to adrenaline. Adrenaline, by the way, is epinephrine, and noradrenaline is norepinephrine. And so what this does is, as we know from the previous lectures, that it does increase alertness and prepares the body for physical activity as well as fight or flight. So we're aware of its sort of physical effects in increasing blood pressure, increasing heart rates, increasing blood flow to muscles, skeletal muscles, for example, increasing or dilating the bronchial tubes for increase in air and so on. Also decreases digestion, urination, but it also has metabolic activity. So glucose levels rise in response to epinephrine and norepinephrine. So just like we saw with cortisol, it also increases glucose levels, and it does so in a very similar fashion. It increases glycogenolysis, which breaks down glycogen in the liver and releases that glucose, as well as increasing gluconeogenesis, so converting things like amino acids into glucose, again via the liver or the kidney. And so that's going to help maintain glucose levels. And so this is actually in some ways very beneficial for diabetic patients, because if their blood sugar goes too low, they may actually get a fight or flight response at rest, as they'll feel their heart rate going up. And if they start to feel their heart rate going up, that's really an indication that epinephrine is being released to help bring up their glucose levels. And so it can actually be a stimulus that warns them that their blood sugar might be low. Pheochromocytoma is a condition where there's a tumor of the chromaffin cells in the adrenal medulla, and what this does is it increases the amount of epinephrine, norepinephrine, and dopamine that circulate in the blood. And this has some of the obvious effects, which would be hypertension, tachycardia, and hyperglycemia. So the hyperglycemia, again, that's due to the fact that epinephrine and norepinephrine stimulate the liver to increase gluconeogenesis and break down glycogen for release to help maintain those glucose levels. So glucose levels become elevated as well. And lastly, what I want to just point out is that although the medulla and the cortex secrete different hormones and respond differently, they're not actually completely independent of one another. In fact, the medulla will actually atrophy without stimulation of the cortisol, so the cortisol actually helps support the medulla, as well as the chromaffin cells of the medulla can extend into the cortex. The benefit of that is that during a stressful period, when the autonomic nervous system starts to increase sympathetic activity, it can stimulate the chromaffin cells, and the chromaffin cells will then stimulate the cortex to secrete corticosteroids, or the cortisol, for example, which helps to activate that stress pathway in addition to the elevation in epinephrine and norepinephrine, so they can act together. So this actually concludes the lecture on the adrenal glands, but please feel free to contact me with any questions that you guys may have.